clarify. Whoever told me they went to clinical and the nurses said it was a clean
procedure.
It is sterile.
Okay.
So I always got hung up on this too because there was a period even within my nursing time where it was just clean, but it is 100% sterile. And one of the session simulations is about trach suctioning and the sterility of the.
Perfect. Thank you.
So, but I did go right back to the educational source and just say, please tell me that is not what you're teaching your nurses, because that's not what we're teaching our students.
Yes, definitely. And that's, yes, Tina.
Check the ties.
Check what?
The ties.
Check the ties.
Okay,
right?
very good. Check the ties.
And if you're ever changing the ties, it should be a 2-nurse procedure. One's going to hold that trach, because if those ties come out, what could also happen? That entire trach could come out. So when you're changing ties, it's not a bad idea to bring a second person with you.
What's with the cup if it's full? Like,
So remember.
Okay, sorry.
Go for it.
No, so if the cup is full, can they talk? Is there different ones that they could talk or not talk?
Remember, what's the important thing about the cuff? When
It should be always full?
Definitely. So when we're trying to actually bag them with a bag valve mask, the cuff has to be inflated. For them to be able to speak, they would either need a fenestrated or an uncuffed tube, because that would allow the air to go over the vocal cords. I'm not going to go into speaking in that type of case. I would go into the idea that in order to do, like, if you're doing CPR and you're bagging your patient, they need to have a cuff, an inflated cuff on their tube. All right.
You got a question?
Yeah.
And I'm not going to be able to hear it.
Is it?
Don't they have to have the safety kit at all times?
Excellent, very good. So what do they need to have at their bedside or within reach at all times?
Suction.
So suction. Okay, what else?
Another size.
Another tray. Excellent job, very good job. So typically you might even see the same exact size and one smaller, right, in case that hole got a little smaller over time. Very good. Okay, good. And a bag valve mask, right? We saw this at the hospital special care. They all had their little kits that they walked around with, right? Okay, good.
The other thing that you might want at the bedside is extra inner cannulas and your actual suctioning equipment, so that if it's an emergency, you're not running to get it.
This is not a test question, it's just a question. Is it more common for the inner cannulas to be disposable or reusable?
Disposable.
Okay.
You're not going to see a metal one very often anymore.
Yes, Jeff?
Isn't it, if it's within 72 hours after they do it, and it's an emergency, if it comes out, like you can't put it back in?
Even
7
within
days. 7 days, sorry.
Yeah, 7 days, right? 7 to 10 days. Mm-hmm.
Okay.
Because that
Eventually then.
that track hasn't become established yet.
Right.
So when after that, we wouldn't want to just pop that back in. The surgeon would need to pop it back in.
7 days. Okay.
Mm-hmm. And when we're actually suctioning a trach, how do we do that?
You want to move it gently.
Suction only on the way out.
Excellent. Suction only on the way out. Very good in circles. What are we gonna? Excellent. Very good. We're gonna do 10 to 15 seconds. Very good. How many passes are we gonna do total? Three. So we can do a total of 3 passes. Very good. Okay,
60
good.
seconds in between?
Pardon?
60 seconds in between, right?
Or
30 to 60?
It's I believe
15
it's
to 30.
15 to 30.
Is it
It's not-
15 to 30?
It's not a full minute.
You're going to hyperoxygenate them.
In between, I remember, yeah.
I have put oxygen on them.
Before. So pre-hyperoxygenate them, right? Very good. And on withdraw. And what are we going to set our wall suction to? What was the load?
1.2?
80 to 120. Very good. So for adults, it's going to be 80 to 120. Okay, good. So what are we going to do if the patient, and remember all those case scenarios that we did? So we have a patient, we're taking care of them, all of a sudden their trach just falls out. What are we going to do? It's been established. It's been in.
Put another one back in.
No.
Good. Put it back in, right? Put it back in. If we're just sitting there. Pardon?
Clamp or something?
Not on a trach. That's chest tube, right? Yeah, there's nothing to clamp. Don't clamp.
Don't clamp somebody's airway. That'd be bad. Don't do that. I'm only joking because you're laughing about it, but just to give you the visual, don't do that.
But even when we talk about chest tubes, though, whenever we know clamp, right? No clamping and no stripping, right? Or milking.
Sometimes, but not when you're moving on.
But we're not. Whenever you see our question, like for our purposes, we're not clamping. We're not going to clamp. Okay. But even
at risk for pneumothorax when you clamp.
Pardon? You're at risk for pneumothorax when you clamp. You're exactly right. Very good.
Let's stay with trachs, though.
Yeah. Sorry.
I'm going to bring us back to trachs.
So we have our inner cannula and we have our outer cannula, right? Okay, it's that inner cannula that for routine care we're going to remove. It's a sterile procedure as well. We're going to put it in that in a sterile solution, right? And we're going to wash it. We had our different tools that we're going to use and wash it, and then we can go ahead and reinsert it. All right, so if our patient is having trouble breathing, right? They're having respiratory distress. What are a few of the interventions that we can take to help them?
Sit 'em up.
Can sit them up. Very good. What else? Suction, very good. What else? Okay, good. What else? I'm coughing, right? I'm clogged. What can I do to help potentially fix that? Take out the inner cannula. Very good. I can remove the inner cannula and see if there's a mucus plug stuck within there that the suction's just not relieving. Very good. Excellent. Very good. Good. All right. So I feel like honestly that is a majority of what we discussed. And even from what we just said, I think you can pick out kind of 5 important things, okay? Yes, Kayla? Come on.
If the trach is dirty and everything, could that be a sign of abuse?
Potentially, if they have like a caregiver who's really doing the care and they're neglecting their trach, potentially.
But they may decide to neglect it on their own. We had a patient who had oropharyngeal cancer who chose to be homeless, and he had come in and again had maggots in his trach.
And sometimes people are just more mucus pluggy than others. There was someone in the ICU. He's probably still there because his family won't let him go.
And then, just so you guys are aware,
crashing.
Hartford, so all of the Hartford healthcare.
So one of the simulations we were working on rating today was actually a trach emergency, so this all ties in nicely, is that all of Hartford healthcare, if you have a trach patient, they are deemed a difficult airway. Just so that you guys go in, which now means they're going to get special bracelets, they're going to have special signage above their bed. So this is all, and there's going to be an algorithm of things that the nurses can do just to kind of make people more comfortable. So this is all going to be coming down the pipeline for all Hartford healthcare facilities.
So,
Yes, Gina.
so we don't need to know the difference between fenestrated and...
No. I mean, the idea basically is fenestrated means there's holes in the cannula, right? Non-fenestrated means there's not. Typically, you're going to see non-fenestrated.
And then the only other important thing with the fenestrated is that you can't suction through that fenestrated. You're going to have to, so you need to know just for that process. So it has to be a fully enclosed inner cannula to suction.
Because if you tried to suction, it's going to potentially go through the hole and puncture the wall of the trachea.
So that's just where it's important just to know that just for every day.
But in terms of speech type of thing, where you're talking about what you can speak with, I'm not going there. Fenestrated, non-fenestrated, all that type of stuff. Really, the primary nursing care that you're going to provide for these trachs, and when it's emergency, what you would do, that type of thing. Thinking back to those scenarios and things that we discussed. Jason?
I'm sorry, when suctioning, if it's fenestrated,
Then you'd have to.
don't get out?
You couldn't suction it. You'd have to actually change it out into a non-fenestrated trach. Sometimes it can just be even the inner cannula piece that can just be changed in that way.
So if you have a fenestrated cannula, do you remove that before suction? Do you need to place a non-fenestrated for suction?
Correct.
Or can you suction without the inner cannula?
Yeah. If the outer cannula was not fenestrated, you could potentially just suction that. You know what I mean? Once you remove the inner cannula.
Yeah. Mm-hmm. So these are 2 questions that I'm afraid to face in the interview. One like this. So if it's fenestrated,
You're not going to.
Okay. The next one. So the next one is my penning. The thing came out. What do you do first? Do you wash? Do you pop it back in?
Just pop it back in. If you're standing right there, it's emergency. It just pops right out like that. You're just going to pop it back in.
You have to.
We are considering
Unless
7 to 10 days.
Unless it's not within that 7 to 10 days.
Okay.
If it's outside of, if it's within that 7 to 10 days, they need to have a provider do it.
Yeah. So, sorry, I'm very anxious about this topic.
Yeah.
It's on the floor.
Yeah.
You pop back in.
No. That's where you hopefully have a trace. You have at the clean one.
So when you say like it fell off, it means like right here.
Yeah, like it fell on the lap or something. And I will tell you, if you see that question on your exam, it's specific. It tells you where the trach is. You are right, but just so you know. The other piece is, sometimes you might see a question, what if just the inner cannula falls out? What are you going to do? Change it. Change it. Pop it back in, change it. You need to, you can clean it, but just change it and pop it back in. The biggest thing to know, what do you think are like the top questions I'm going to ask you about this? What is like buzzing in your brain about trach?
What if they go into respiratory distress, maybe?
What if they go in respiratory distress? So we're talking about suctioning, we're talking about removing the inner cannula. What else did you guys say?
Change the tie.
I'm not going that far. What did you say?
Sterile.
How many passes, that type of thing? It's sterile. Very good, Luciana. This is a sterile procedure. Very good.
And then just remember, suctioning is a intervention. What do we always do after an intervention?
Assess.
Reassess, right? So don't forget that reassessment of your patient piece.
After we suction our patient, what are we expecting our outcome to be for our patient?
Better breathing,
Higher O2 stats. Very good. Very good. Breath sounds, right? We may expect clear breath sounds, increased pulse ox, okay, decreased work of breathing. Excellent, very good. Okay, good. So that evaluation as well. Okay, good. I think you guys got this. 5 questions.
We just covered 2 here.
Well, what else did we talk about? What else did we say?
We talked at least like 10 questions in that like 5 minutes.
Don't forget to put your finger over that whole thingy, set it at 80 to 120.
Always suctioning on the way out, right?
On the way out.
3 passes, sterile
10 to
procedure,
15 seconds, 15 to 30 in between,
right?
oxygenating in between and before.
I mean, through what we discussed, right? I don't have all the questions memorized in my head, but we've definitely hit everything that you're going to see. Okay? You guys okay with this? Also, use the worksheet that I gave you, right? We had a worksheet in class. It gave you questions to think about. Basically they're introductory, like what is a tracheostomy? Why do you have it? How do you care for it? That type of thing. But just review that in your head and make sure you have a good understanding of that. Rewatch. Rewatch. A simple nursing video or things like that. Those are pretty good on these topics as well. Okay. So then we went to central line. Okay, so what are some things that you guys need to know about central lines?
Sterile.
Okay, again, we're talking about sterile. Okay, very good. When we're talking about central line dressing changes, that's going to be a sterile procedure. We're going to mask the patient and mask ourselves. Very good. What else?
We get the chlorhexidine baths.
Chlorhexidine baths. Very good. What did you say, Luciana? Did you say anything?
No food.
Pardon?
No food.
No food?
Yeah.
For central, what do you mean no food?
Oh, no TPN, you mean?
Yeah.
No.
Just say central line.
That's what say you don't put food in there.
But we're just talking about the central line dressing, the central line itself.
Okay.
Maybe like the locations of it,
Okay, very good. We talked about different sites of it. We talked about different types of it. One thing I want to make sure you guys understand, what is the difference between a PICC line, so a peripherally inserted central catheter, and just like a HEP lock or peripheral catheter?
One goes to your heart.
One goes to your heart, right?
PICC is central.
PICC is central, right? So just I want you to understand that terminology, that difference between PICC and that peripherally inserted central catheter. And if you just see like peripheral line, that's not going to be a central venous access device, right?
Is a midline a central?
No. It's not just called, and that looks the same too, right?
Yes, and midline's going to look similar to a PICC. Yes, when you're changing it, you're going to turn the patient's head. Very good. Okay. What kind of catheter do you need to use when you are flushing a PICC or a central line? 10 cc. Very good. So we need at least a 10 cc catheter. Why? The pressure, right? If we don't do that, we're going to have too much pressure. If you did a smaller syringe, we're going to have too much pressure in that syringe as we flush. What's the technique that we use when we flush a central line? Push pause. Very good. Excellent. Push pause. And why are we doing push pause?
So you don't cause
You got it.
air.
You got it. You're on the right idea. Not air, but what?
It builds up too much pressure, right?
It's clot. Who said that? Excellent job, Sarah. Tell me.
Oh, so the line spotted, you just did a push.
Excellent. Very good. Excellent. It gives you a little friction in the line so that you're not, if you're helping, if any blood was pooled there, you might break it up, but also to prevent any blood from pooling in that way. Very good. What do we talk about when we have, what are some risks with a central venous access device? What are some complications?
Infection.
Okay, so infection is huge. Very good. What else? Air embolism. Very good. Okay, what else? What did we just say? What did Sarah just tell us? Clots. Very good. So clots. Very good. Okay, good. We can have even like catheter migration or movement. So what is really important that we do before we, what'd you say, Sarah?
Placement.
How do we check for placement? X-ray when it's first used, but after that, what are we going to do? Blood return, right? We never want to just flush anything blindly until we have our blood return. Okay? Good. What else can we talk about with central lines? What are the different types that we talked about?
Portacath.
Excellent, a portacath. When would a portacath be used? Chemo, cancer, that type of thing. Very good. Good. What other, we talked about a PICC line, right? Very good. We've talked about just a central inserted catheter. We talked about tunneled versus non-tunneled. What's the difference between tunneled versus non-tunneled?
Tunneled is longer lasting, PICC line is shorter, or non-tunneled is shorter lasting, like same as a PICC line.
Very good. And what is the actual, what are we actually talking about when we talk about something being tunneled?
It's inside.
It's implanted.
Okay. So remember, tunneled is an idea that if we actually, so in if just a centrally inserted non-tunneled catheter, we're just inserting right into the central vein there, right? If we have a tunneled, we're talking about, okay, this is the patient's belly button. We're down in the patient's chest. This is the insertion site. We're tunneling underneath the skin until we get in there. So it's just the farther away from the site. Okay, this has less of a risk of infection. All right, and these can be used for longer. Remember, they also can have little, oh goodness, I'm blanking on the name, but the Dacron cuff to help them adhere inside, right, so they can stay put. All right, so they're not migrating or anything like that. Okay.
Sorry, which one has less risk of infection?
The tunnel. So when we're actually tunneled underneath the skin, before we get to the site, before we get to the major vein there, we have a less risk of infection as opposed to just the centrally inserted. So if we just go directly into, say we're using the jugular vein, we go directly into the jugular vein and then going over to the right tunnel, or getting ourselves to the right atrium, that would be more of a risk of infection as opposed to starting in their abdomen or wherever and then trailing ourselves up to the subclavian or wherever we may be. Okay? Yes, dear?
Is it a sterile procedure when you remove the catheter?
No. Mm-hmm. And you can, IV therapy nurses, even floor nurses, depending on where you are, may be trained to remove them. Other question, what are some uses? Why would someone have we talked about a port. So a port is, remember, implanted underneath the skin. In class, we talked about the idea of there being power ports versus non-power ports. And power ports are more supportive of like contrast dye and things. Do you have a question?
No, I don't.
Oh, just stretching. That's fine. But what are some other reasons why we would have a non-implantable port? Why would someone have? What would be what are some uses if someone had a tunneled catheter? If someone had a PICC line, why are these other central catheters used? What are their purposes?
PICC time is long-term antibiotics.
Long-term antibiotics. Very good. What else? TPN. Excellent. Very good. What else? Well, dialysis is a different type of catheter, right? So that's going to be a more specific type of catheter. These are not for just what we're talking about here, like central venous access. What else?
Blood products.
Blood products, okay. Depending if they're having multiple, right, or things like that, because we can use just a peripheral IV for blood products. TPN, excellent, very good. There's one other thing that we could potentially do with them. Okay, good. We again could use if they need multiple medications at the same time, often like an ICU patient might. And remember sometimes we can do like central venous access monitoring as well. So we like a Swan scans catheter, that type of thing. But you guys hit them. Otherwise, you guys were good. Okay, so we're not going there. That's more of an ICU thing. But just knowing the idea that we can do hemodynamic monitoring through them as well is the point to know.
So basically, the key thing with the central lines is that they all basically go to the
right atrium.
Right atrium.
So the tip is going to lie in the right atrium.
And they can be, if they could be tunneled, non-tunneled, it
Yep.
could be a port, yeah.
Yep, they can be.
Right. And then just think about the advantages of each one and the length of time. Like somebody could have a portacath for years and years and years, right? Whereas somebody who has a PICC line, we're really not looking at more than like 6 weeks, right?
Mm-hmm.
Like that's really the length of time for that. Versus somebody who has a Trippin lumen catheter, that's literally going to be the duration of their ICU stay, and then even before they go to the floor, that one's coming out, right? So just kind of think about the length of the time and what your overall use of the central venous access device is.
Okay. You guys feel okay with that concept?
Are you confused?
So we have.
A lot of lines they be confusing. So PICC line exactly what it is?
So the PICC line is the one that kind of goes in like around your bacillic, right? So it's like a catheter that comes out. It's a peripherally inserted central catheter. So it's going to be here, but it's going to go all the way into your right atrium. The tip is still going to sit there. But the PICC lines are typically either a single lumen or dual lumen. Charlotte puts them in people who they can't get IV access for, whereas like other people will go home with them, like say they have osteomyelitis and they need that long-term antibiotic use, they'll go home with a PICC line so that they can continue to get outpatient IV antibiotics.
It's short-term use.
Short
Right.
term.
In my head, 6 weeks is long-term, but yes, it really is short-term.
It's all relative.
Yeah, no, I just, like you would never be able to use a just regular IV for 6 weeks.
You guys okay with that though? Okay, so definitely reviewing the dressing change and that type of thing, but then also reviewing just that little lecture that we did on the different types and uses and that type as well. Okay? All right. Let's talk about chest tubes. Okay? So we're going to primarily focus on wet chest tubes. All right? So when you first think of a chest tube, right, we have our 3 chambers. So what are our 3 chambers?
Middle one is water seal, right?
Excellent. Water seal. Suction control would be our first one. And what's our last one? Collection. Very good. Excellent. Good. What are some important principles to know about our suction control chamber? It should be bubbling. How would we describe the type of bubbling that we should see in our suction control chamber? Gentle, continuous bubbling. Can you guys all hear Nurse Mike saying that? Gentle, continuous bubbling should be what's happening in our suction control chamber. And that makes sense, right? Because what's happening in our suction control chamber?
Pulling out water.
It's pulling out water, right? And this is where our suction is attached to, right? So our suction is attached right here. We're attached to our wall suction, and we're having gentle, continuous bubbling. Okay? Tell me about our water. And this is going to be filled up higher. So this is going to typically be like 40 centimeters of sterile water. Okay? Our water seals, and you guys do not need to know this, but this is typically more like 2 centimeters. But anyhow, not more of a minute detail. What is the other word that we can talk about when we talk about our water seal chamber?
Air leak.
Air leak. Excellent job, Gina. Air leak. Very good. Why do we call this our air leak chamber?
If there's continuous bubbles, it means that there's an air leak.
Excellent. If we have continuous bubbling in our water seal chamber, we have an air leak. Okay? Very good. If we had an air leak, what would we do?
Check the line.
Check the line, right? We need to start at the patient and get us all the way back to the system and check to see if we have an air leak, right? We have a break in our system. So where is that? What is it called when we have the fluctuation in our water seal chamber? Titling. Very good. What should we expect on titling on inspiration? Up. Very good.
Unless they're
Exactly. So you guys were right. When the patient is intubated, so normally titling, when you inspire, the water rises. When you expire, the water drops. When the patient is intubated, it's going to be the opposite. So when you inspire, it goes down. But if I saw, does everybody got that okay? So
Expiration, it goes down.
So at normal titling, the patient that's not on a ventilator, when you inspire, the water goes up. When you expire, the water goes down. If the patient is on a ventilator, it's the opposite. Just with the change in the pressure. Okay? What would it mean if all of a sudden, or if I noticed that there was no titling in my water seal chamber? What would that indicate to me? A kink
An obstruction
or
or something?
Excellent, very good. So it would mean there was either a kink or obstruction within my tubing, or that the lung has re-expanded.
And they don't need it.
If I notice that the titling stopped, what would be my first assessment that I would make?
Breath sounds.
Breath sounds, very good. Looking at the patient and looking at the breath sounds. It's going to be very different if their lung is re-expanded versus if there's a kink in the tubing, right? Okay? Very good. Excellent. What are important principles to know about our collection chamber?
Was it over 100?
Excellent. Very good. Excellent. If we had greater than 100 milliliters per hour after that first hour of the chest tube being inserted, we would want to notify the provider. Okay? Good.
Of just blood or any kind of fluid?
Any kind of fluid. Because remember, the other thing that's important to think about when we talk about having a chest tube is why the patient has the chest tube, right? Because if we're talking about a patient having a pneumothorax, right, and their chamber is filling up with 90 milliliters of blood every hour, I'm wondering what's happening. Okay. Also remember, yes, Pauline.
Can you just clarify after the first hour or within the first hour?
After the first hour. Mm-hmm. Basically, it's just giving them some leeway that in that first hour they might have more drainage just because when it's first inserted, they may have more, and then after that we wouldn't want to see more than 100. Okay? In the collection. All right. So good. What is the purpose of a chest tube? What are we doing? Re-expanding the lung. Very good. So where is that tube being inserted?
In the pleural space.
Excellent. In the pleural space. Very good. So this is happening, right, in that pleural space. So this is happening here, right? So here's our lung, all right, the outer pleura, and it's going into this pleural space here, okay? And we have some different things that can be in here, right? Okay, so we talked about we can have like pus, we can have lymph fluid, pus, that type of thing. We can have air, we can have blood, okay? So different things can fill here, okay? Good. What else? Okay, so what are we going to do if the chest tube falls out of the patient? What are we going to do? Cover the wound. With what? Petroleum jelly gauze, very good. And how many sides are we going to occlude it?
3.
Pardon? Occlusive dressing, very good. Why wouldn't we want to occlude all 4 sides?
You still want air.
Air to come out, very good. If we occluded all 4 sides, what could we potentially cause? Pneumothorax, very good. So remember on a lot of these complications, we kept saying pneumothorax. Okay? Good. Awesome. What are we going to do if our tubing, so we're on our chest tube, right? Here's our tube. It's coming here, and now it gets disconnected from our system. What are we going to do? Put it in water. Very good. How much water are we going to put it in?
100.
It's usually you want like 100 bottle, like 50 cc's of water, things like that, and then it's going to just reestablish that suction. Okay. Good. So just in the sterile water there. What is another word that we can call the actual chamber, our drainage, our whole collection system here? What might we refer it to? Just in case you see this. Remember the word atrium or atria? Sometimes they may call that atria. I don't think I used that terminology in your test, but
what is it again?
An atria or your atrium.
It's a whole the whole system.
Right, so if you were to fill that entire collection chamber, instead of like removing the whole chest tube and everything, you can just change that hard plastic 3-chamber system.
What did I forget? Because I feel like through what we just discussed, we have way more than 5 questions.
Are you going to ask us about like checking for crepitus and all that?
You can't. I'm not. But that's a good point to bring up. Yes, that after it's inserted, we would want to mark for crepitus, and if we felt crepitus, what would we do? Mark it. Very good. And then we would go back and reassess, and then if it expanded, then we would, call the provider and things. Okay, but that's a good point, Gina.
So bubbles on the left are good, bubbles in the middle are bad. More than 100 milliliters after the first hour on the right is bad.
Mm-hmm. Remember, bright red is bad. Bright red blood is bad blood. Honestly, I will share with you also, watching that Simple Nursing Mike video, Nurse Mike's video, that's a great review. He gives you a lot of good points there. Yes, Amber?
I thought they're supposed to be just a little bit of bubble in the water.
So the water seal chamber it's not truly, it's like when they cough or things like that, you can see bubbling. It's more the titling that you're going to see the fluctuation, and the cough where they change in the pressure, but not true, gentle, continuous bubbling. Okay.
And just remember, this is for the wet, the wet system. A lot of hospitals now are using like the dry So that first chamber, instead of it being water, is that orange bellow that kind of balloons out. So that kind of does away with that. But for whatever reason, even though we're using the dry systems, NCLEX still brings up the 3, like the West Seal. So we know there's other things out there. We're just teaching to the most complicated.
But honestly, NCLEX typically tests you on, for right now, NCLEX is typically testing you on the wet seal. That's why you'll see those types of questions. So it's important to know. But I think, can you guys definitely tell me 5 things that you think you could write the test on this content?
Mm-hmm.
What am I going to ask you? If the tubing disconnects from the patient, right? If the tubing disconnects from the atrium, what are we going to do if the atrium just falls over? Pick it back up, right? What are we going to do if the atrium becomes broken or smashed or whatever?
Replace it.
Yeah. Where do we always want the atrium? Below. Very good, right? We never want it up on the stretcher. It should always be below the chest, right? Okay. Good. You're going to know these chambers, right? You're going to guarantee you're going to see something about bubbling, and something is going to be wrong with the bubbling, right? And you have to be able to identify that. Okay. Knowing about the output. All right.
No stripping, clamping,
no stripping, no clamping, or milking, right? I just like to say that. But again, even Nurse Mike goes over that as well. So. Okay. Good. You guys okay with this? Okay. I will share with you guys though. I feel like this test compared to your other tests, like it's more task-based, right? So I feel like if we've talked about a lot of these things. I hope it's an opportunity for many of you to kind of feel like you can even do better. Not that you're not doing well, but an opportunity to have a really strong test score before you go into the final. Okay. All right. Let's talk about ostomies. We just talked about that. What do you think we need to know about that? Body image. Very good. So definitely pardon?
Measure the wafer.
Measure the wafer.
An eighth bigger.
Very good. Right. It should just be an eighth, right? About an eighth of an inch bigger. It's 3 to 4 millimeters bigger. When do we empty the pouch?
When it's about half full, maybe 2/3 full.
A third to a half full.
Oh, a third to a half.
Right, very good. Some resources are even saying just a third. Very good. Good. Okay. How many days should it be between the actual full device is changed?
3 to 4.
3 to 4. Excellent job, Rachel. Very good. 3 to 4 days. Okay, good. Excellent. What should we know about the location of the stoma or the ostomy and the type of stool that's going to be put out? Excellent, very good. The higher we are in the GI tract, the more loose that stool is going to be, right? So the more liquidy the stool is, what are we at risk for? Dehydration and electrolyte imbalances, right? So being aware of that, okay? Good. I just had something else that came to me. Definitely knowing as we go through the GI tract, the changes in the stool, where would be the location that we would have the most formed stool? Sigmoid, very good. Remember also knowing the difference between, we talked about a single barrel versus we talked about a loop versus we talked about the transverse, right? Okay. So those of you who haven't had lab yet, you will get this on Wednesday and Thursday, so it'll be fresh in your head if this sounds like crazy talk right now. But remember with the loop, it's actually the two pieces being brought up kind of right next to each other. And what's going to drain out of the proximal side of the ostomy? Stool. And the distal? Mucus. Very good. So distal is mucus and proximal is stool. Okay? We can educate our patients about different gas-producing foods, right? Odoriferous foods and that effect that might have. We talked about the idea of not giving patients, especially higher up in the GI tract, like an ileostomy, enteric-coated medications, because those might pass right through. We've talked about the idea of like nuts, especially higher up, like nuts, seeds, and that type of thing, clogging or things like that in the ostomy. Again, Nurse Sarah, the questions I have posted are a good resource for you to review as well. Even using that American Cancer Society website, that's what we use in class, just to review that as well. But there's 4 questions here, and I feel like, what should the stoma not look like? Black, purple. How do we want it to look?
Red, beefy.
Red and beefy, right? A beefy red, it sounds bad, I don't know. A beefy red stoma. Okay, very good. Good. Excellent. You guys feel okay with this content? That should be more fresh for you guys. We just did it in lab most recently. All right. Then under my content, I'm not going to go into this. I'm not going to go into every med right now, but there's a list of medications for you on your sheet, and you're going to need to know 8 of those. Okay. I can tell you just though, from those 8 medications, you know, I mean, I don't remember exactly how many are there, but out of those classes of medications and things, it's really the big picture things, okay? So adenosine, SBT, asthma, or albuterol, asthma, right? Your short-acting beta agonist. Don't use long-acting beta agonist alone for asthma, right? Just for COPD. So just knowing what are the corticosteroids, and we spent a lot of time talking about corticosteroids and side effects and that type of thing, okay? So I promise you kind of big picture points there, okay? I'm not going to spend the time talking about each of them individually, but use the PowerPoints that I created and study those and you'll be just fine, okay? And those will actually give you a help for all this is a help for the final, but a lot of those meds are on topics that aren't necessarily on this exam. But yes, Jess?
I'm probably getting into it too, I'm sorry, but on the blueprint, are we doing any cardiac, anything besides the meds?
No.
Because that was all with cardiac.
Correct.
I just don't have enough hours in lecture to do it.
Okay.
So the only, yeah, you're exactly right. Oh,
It'll come back on the final.
Right, but not for the lab from that pull out.
Do you want them on this exam?
No.
Then why does it say we'll see 8 of these medications?
So you'll see. So I gave you
It says adenosine, amiodarone.
You're
So
see,
we'll still.
So you can see
Right, but they're talking about EKG interpretation and things like that. That's not on this exam.
Oh, so more for just the meds, not what you would give it for.
Yeah.
Okay.
I will tell you, you will see an insulin question. Okay, so review your insulins. All right, and you will probably see I will make sure you see an insulin question on the final as well. I think insulin's really important. You take away from everything. All right, so that's that. Environmental health, as I shared, they're very broad, basic questions. I'm not trying to trick you here, just kind of basic things that we talked about. Definitely review those, like lead, mercury, and those other asbestos, those pieces that I put. And then just basic ideas of climate change and things that we discussed, okay? If you have the opportunity, I would suggest just reskimming that text that I provided you. You have to register yourself and then download the e-text, but it's actually a pretty cool reference. And actually, one of our professors, she worked at Naugatuck, but she actually helped write that. Her name is Kathleen Murphy. She helped write part of that textbook, so that's kind of neat as well. And it will get you hooked up, so it's the Alliance of Healthcare and Nursing Environments, and that will get you onto their website, and you can see their resources as well. Okay? And then tertiary prevention, you can guess what one of the questions is going to be, right? Just applying, probably 2 just application of the questions. And then patient care round, pretty basic what we talked about today. There's 2 basic questions on that. And then dosage stuff. Okay? And that's what I have for you. Do you guys have any questions on that content? Yes, ma'am. Pardon? Joanna's going to review her content.
There's 2 more things that we got to talk about. So the first one is the parenteral nutrition, or the TPN, right? So for one lab group, the group that'll be here Wednesday and Thursday, this is kind of all like foreign to you. But for the other 3 groups, what are some big key takeaway about TPN? What kind of line does it have to be run through? Central. Right, so a central line, right? So that's a great place where we can kind of tie into content areas in one. If you were to run out of TPN, what is the
Dextrose.
D10, right? So dextrose 10 would be what we would hang. Remember, we never play catch up with our rate, right? So if for some reason there was a delay, or like it was kinked, like the tubing was kinked for a prolonged period of time, you never run it really fast, okay? It just has to be a constant rate. What are some of the complications that can happen with TPN?
Hypoglycemia.
Right, so hyperglycemia while it's running, hypoglycemia if it is stopped for a period of time, right? Our TPN is very hyperosmolar, so it can cause some of those issues. Remember, in the hospital, they have to have lab work drawn every day, and they're going to titrate the list of ingredients based off of somebody's lab results, right? So TPN is going to be patient specific. Like, you can't use my TPN on NOM. You can't. It is going to be patient specific. We talked about it needing to be. Let's see, what else? What are some other big key things that I'm missing?
Room temp.
What's that?
Room temp.
Room temperature.
Right, so no microwaving your TPN, right? We want to let it sit room temperature for at least an hour before you're actually infusing it. But when you're not, like, so for at home, they'll get a week's supply of TPN. It'll sit in the refrigerator for that entire week, and then they'll pull it out an hour or two before they actually infuse it. Once TPN is out of the refrigerator, how long do we have to infuse it?
24
hours.
24 hours, right? So after 24 hours, we have to change it to a new bag of TPN. We can't keep using it. All of our tubing has to be changed. We talked about vital signs with TPN, right? So this is where I said, if I were to ask you about vital signs, you would see the range, because your book says 8, ATI says 4, or vice versa. So you would see vital signs every 4 to 8 hours, right? Like you would see a range versus me giving you one or the other to accommodate for both resources that we have. Remember, when you're running TPN with lipids, what do we have to remember we use? A filter needle, right? So a 1.2 micron filter needle when we're using the lipids. Was there a question back there that I just like blew through?
4 to 6 or 4 to 8 hours.
4 to 8. Sorry, I might have said 4 to 6, but it's going to be 4 to 8. It's going to be, if you were to see it. And I'm only saying that because when we did the Kahoot, I remember that question being there. So
that's vital sign, right? 4
yeah.
to 8. 4 to 8.
Remember, our patients in the hospital are going to be NPO, therefore they're going to be finger sticks every 6 hours, right? So they're going to be like that 612, 612. Let's see. Change your tubing every 24 hours. We talked about our hypoglycemia. We could potentially have refeeding syndrome. We could technically see if it's used long term. You could see gallbladder issues. And then I think that's really, I don't think there's really anything else with TPN.
Finger stick is how often?
Every 6
every
hours.
6 hours.
So vitals are every 4 to 8, and finger stick is 6 right in the middle, 4, 6,
Right.
8.
There you go.
So the range is patient, it's by the patient, right?
So at home, it's going to be like by the patient, but in the hospital, there's usually a policy that tells you, and because in the hospital, it's usually running for 24 straight hours. At home, they'll typically do like a 12, 14, 18-hour cycle. So they'll slowly increase it, run it at their goal rate, and then slowly decrease it. Whereas at the hospital, once you get it to that maintenance, your goal is that at that 24-hour mark, you're just changing it and keeping it running.
So we're not using a rate for the exam.
You don't need to know anything. It's just that you wouldn't rapidly increase it just because it wasn't running. So then I think that's good about the TPN. Then there's the population health, right? So that was your first day of the lab pullout. And yes, we talked a lot about Connecticut data. So this is where we got to kind of take it back and look at it more broad. Like, do you understand what social determinants of health are, right? One's socioeconomic status, their education status, like where they're living. Understanding that upstream approach, right? Like really going beyond and looking at things from that upstream approach versus just kind of putting a Band-Aid on things to make it better. We talked a lot about health disparities. So I'm not going to ask you about like Connecticut's health disparities, but do you understand what makes somebody at risk for having a health disparity, right? And that's often sometimes tied back to their social determinants of health. Then we talked a little bit about equity versus equality, right? So we had that little graph, that picture of the people on the fence, and we talked about what often is the difference between equity. Our goal is equity versus equality. I also told you on the exam review to know the IHI triple aim. Literally going to be a drag and drop. Understand the 3 components of the IHI triple aim, right? So just make sure you look at the PowerPoint for that. And then the other thing that I referred to you is to look at the primary, secondary, and tertiary prevention, because that is all related back to population health. It's going to be very broad and really not a lot of like what we talked about. It's more going to be understanding the social determinants of health, what health disparities are. Could you identify a person if they were to have a health disparity? What are some of the barriers to accessing care, right? So think about people who have to decide about whether they work and put money so they can buy food versus taking time off and going to the doctor, right? So if clinics don't have evening hours, that's going to be a barrier to your patient who needs to work, right? So just kind of thinking through some of those pieces. But very basic. And then I think that's everything, because we talked about trach, central line, chest tubes, oxygen, meds, mandated reporting, really understanding child abuse, elder abuse, and that we also had to report other disease processes, including STIs. Parkinson's we talked about today. I would understand your meds. I would understand basic safety and understanding those, recognizing your cues. I think that's it. Lots of hundreds.
You guys are doing it.
Lots of hundreds next Monday.
90. Let's go 90.
I did look at the statistics from last year. They were pretty high.